Hello.
Yes, sir.
Yes, we were discussing the last part of heart failure. Medicine we use, the drugs we use at the time of starting heart failure. So, what was the principle of heart failure treatment? We must decrease the preload, we must decrease the afterload. Clear? So, we use RAS blocker for heart failure the first. Must use this drug first, then add diuretics. Then you also can use hydrazine. You can use beta blockers also, especially labetalol and carvedilol. Okay, so before we're just trying to reduce the preload and afterload, because why you're doing this, heart already much weak. Yeah. So now when this topic, patient not tolerate, patient not give response to this therapy, the above given the principle here, decrease preload and decrease afterload, this principle of therapy now fail. The heart is further, the patient condition now getting more worse. Then we only have the last hope. We give inotropes. What the inotropes doing is strongly contract the heart, strongly contract heart. They strongly contract your heart. Okay. So these inotropic agents, inotropic especially here for the heart failure, the digoxin. Digoxin, another having the inotropic, the glutamine, another milrinone, milrinone, amrinone. These all drugs, this one, especially act on the special type of channel, how it acting directly increase the calcium. Okay, and the glutamine act on beta 1 receptors and increase the calcium. And these drugs, these are phosphodiesterase inhibitor, milrinone, amrinone, and they also at last increase the calcium. You can see all these drugs they increasing the calcium. Clear? So increased calcium is known as inotrope. Inotrope. Positive inotrope if they increase calcium. So they increase calcium. If you increase calcium inside the muscle, what happens next? Contraction. What happens next? Strong contraction. So this is the only last hope in treating heart failure. At last, not directly start therapy from digoxin and vitamin and milrinone. First we first we just try to reduce afterload and yeah, reduce afterload and preload by blocking RAS system, by blocking aldosterone, by blocking angiotensin 2, by blocking sympathetic system. Clear? Using diuretics, dilate the artery, dilate the vein, just to reduce the preload around. When this therapy fails, at last, you come for inotrope, digitalis, digoxin, clear? The glutamine, milrinone, and amrinone. Amrinone. These drugs they increase calcium inside. So they increase calcium inside. Now you're doing what? Now your heart is weak. Now we doing what? Now we supporting heart. We support heart. For what? Support heart for contraction. Heart already much failure. Yeah, already much in failure condition. But now we support the heart muscles by giving extra calcium. Few muscles still strongly contract. Okay, support the heart for contraction using which group? I know proteins. Understand? Which one is the biggest and important thing here? Digoxin. Important thing here, keep in mind, digoxin. Okay? Also known as glycoside. Part here, glycoside. Part the glycosides. The plant name coming digitalis, digitalis. Also known as digitalis or digoxin. Same thing. Okay. Digitalis and digoxin. Digitalis and digoxin they are the same thing. So we use, but the problem with the digoxin, the very important digoxin here. So what are the side effects of digoxin? Side effect digoxin doing what? Digoxin increase calcium, increase the calcium inside the cardiac muscle and increase contractility. What's the problem with this drug? This drug therapeutic effect, therapeutic index, therapeutic index very low. It means this drug very easy, very easy to become toxic. Therapeutic index very narrow, very easy to become toxic. The main side effect, digoxin. Therapeutic index very narrow. Therapeutic index very narrow. So digoxin toxicity. Digoxin, what are the side effects of digoxin? So what are the digoxin is doing? Digoxin cause arrhythmia. Arrhythmia. Digoxin causing can cause seizure, CNS problems, convulsion. Digoxin also can cause GAT upset. GAT, nausea, vomiting, upset. If digoxin very high, if digoxin become toxic, okay. If digoxin become toxic mean very high dose. Digoxin become toxic, it can cause arrhythmia, seizure, CNS convulsion, confusion, seizure, confusion, GAT upset, nausea, and vomiting. Okay, now question here, very important question about the digoxin. What are the risk factors? What risk factors are risk factors are digoxin toxicity. Risk factors are digoxin toxicity. Clear? So what risk factor? Number one, most important here, renal failure. If patient have already kidney issue, renal failure. If patient have already kidney issue, digoxin can be toxic. If the patient have electrolyte imbalance, if the patient have potassium low, if the patient have calcium low, hypokalemia, hypocalcemia, okay. The patient have low potassium, electrolyte imbalance. It's also very important. Electrolyte imbalance. Low potassium, must keep in mind this one. Low calcium. It can cause digoxin toxicity. If the person is using diuretics, person using diuretics, diuretics, if person also using, heart failure patient on diuretics, yeah, we use diuretics in heart failure patient, already taking diuretics for heart failure, and person using diuretics, these diuretics, they reduce calcium, they reduce potassium, they reduce sodium. What happens? Electrolyte imbalance. When electrolyte imbalance lead to digoxin toxicity. Understand? Digoxin toxicity. So electrolyte imbalance is very important here. Diuretics, electrolyte imbalance, renal failure. Okay, another drug, antiarrhythmic drug, amiodarone. Later we learn in the arrhythmia lecture, amiodarone. amiodarone, quinidine, quinidine, and one calcium blocker, verapamil. Verapamil, verapamil, amiodarone, quinidine. These are antiarrhythmic. These are antiarrhythmic drugs, and they also induce digoxin toxicity. So these are the risk factors for digoxin toxicity. Digoxin in toxic state causing what? Erythema, seizure, confusion, GAT. Affect brain, affect heart, affect GAT, if you know about it. And what are the risk factors for digoxin toxicity? Number one, if the patient has kidney problem, must take care when you use digoxin. If patient have electrolyte imbalance, patient on diuretics, patient on anti-arrhythmic drug, amiodarone, clonidine, and verapamil. In these drugs, they induce digoxin toxicity. Clear? These drugs induce digoxin toxicity. Digoxin, what is digoxin? It's the inotropic. But another option, inotropics, you can use glutamine, you can use milrinone, you can use amylin. The most important one, keep in mind, digoxin. It's all about heart failure. Okay. What was the fifth group we used last? In addition to these drugs, when this therapy, this therapy fail, okay, decrease preload, decrease after this concept fail, this principle fail, then you must go for inotropy, support the heart contraction, support the heart for contraction. Okay, how you support? You support by using inotropy. They increase calcium. Understand? So which drug is important here for as inotropic? Digoxin. What's the problem with digoxin? Easily can get toxic, easily can cause toxicity. What are the problem with toxicity? What happen in toxicity? It can lead to seizure, convulsion, confusion, GAT upset, nausea, vomiting, and arrhythmia. Okay, it can cause arrhythmia. And what are the risk factors for digoxin toxicity? If the patient has kidney disease, patient has electrolyte imbalance, patient using diuretics, patient using amiodarone, quinidine, rapamycin, these drugs reduce digoxin toxicity. It's all about heart failure. Understand? Now the summary here. Last thing, the heart failure, cardiac output was low, so that's why blood pressure was low. Two systems working together to increase cardiac output and blood pressure. Sympathetic system and RAS system. Both systems, this system increase preload also, increase afterload also. Understand? And sympathetic system increase afterload and also try to increase heart rate. So all these two systems working and to compensate. If you can compensate, it means compensated heart failure. Understand? It's still low, like these two systems working, and RAS and sympathetic. What happened? Heart still fail. Heart still fail. Not able to maintain both system active, but cardiac output still low. So now it's mean heart now in the compensated failure. Now what we do? Preload and afterload. You must reduce. Understand? Preload and afterload. You must reduce. How we reduce? Using now it's time to use medication. Understand? Now first we try to block this RAS blockers, angiotensin converting enzyme inhibitor, angiotensin receptor blockers, renin inhibitor, aldosterone. These drugs, Brill family, sartan family, and L-ascarin and spironolactone. So these drugs they reduce the preload and afterload together. Understand? And the first group, the second group we use diuretics. Third group we use vasodilator, vasodilators, and fourth one we use beta blocker. We start therapy from RAS blocker, then go for diuretic, then go for vasodilator, then go for beta blocker. At last, when this fail, now what you have now? Let me know. Number 5. Inotropics. Okay. Inotropic. Which one? Digoxin, butamine, milrinone, and amrinone. Understand? So what they're doing is support the heart for contraction. Support heart for contraction. Clear? So because this principle was failed now, we've just now doing preload decrease, afterload decrease, but this therapy, preload decrease, afterload decrease, no more working. So patient still in failure, so we must give inotropics at last. Not start from beginning, okay? For heart failure, you must start your therapy from RAS blocker, understand? Then add diuretics, you can add beta blocker, you can add vasodilator. These 4 drugs first use before going to inotropics. Clear? Inotropics must use at last. Understand? It's all about heart failure. Next class, inshallah, we will start MI and angina. How to treat MI and angina. Okay? What drug we prefer for angina and MI. And that's what for the class. If you have any question, you can ask me from heart failure. Must read my PPT. I already sent in group. Usually now you can memorize easily everything I explained. Have any question?
No, sir.
Okay. Heart failure done, all guys.
Yeah.
If you feel any difficulty understanding about any drug, must ask me. Okay, no problem. Inshallah, tomorrow we will start ischemic heart disease, angina, and MI. Okay. We'll see you tomorrow, inshallah. Assalamu alaikum.
Waalaikumsalam.
Waalaikumsalam.
Hafiz.
Allah Hafiz.
Thank you, sir.
Welcome.